Hi, this is Dr. Buhler, and we're going to talk about female sex hormones and the hypothalamic pituitary gonadotropin axis for estrogen and progesterone. So estrogens, progestogens, and androgens are all part of the sex hormone class. All of these are derived from cholesterol, and all of them have a steroid backbone. The female sex hormones are progestogens and estrogens. These act at separate receptors, so we have a progesterone receptor and an estrogen receptor. Progestogens are a larger group that act at the progesterone receptor. They include progesterone itself, which is the natural hormone, and they include progestogens, which are synthetic agents at this receptor. We have a lot of drugs that are agonists at progesterone receptor, and we use those in oral contraception. And we have some drugs that are antagonists at this receptor. We also have a really important drug that is a sperm, great name, which is an agonist at some cells and an antagonist in other cells. And we'll talk about that in more detail. Over here with the estrogens, we've got estradiol, which is the specific compound that is the highest concentration of an estrogen in the body. So when we refer to estradiol, really just say estrogen. And when we say estrogen, we mean estradiol. So we've got estrogen itself, and then we've got synthetic forms. We've got agonists at the estrogen receptor, but we don't have antagonists. So if we want to block estrogen effects, then we have to block estrogen synthesis. We also have SERMs, which are selective estrogen receptor modulators, which act in some cells as agonists and in other cells as antagonists. And again, we'll be talking about those. So an endocrinologist would say that this diagram is extremely simplified. For our purposes, this is exactly what we need to know how contraceptives and other sex hormone drugs work. All steroid hormone pathways are very similar. Down here in the right-hand corner, you can see that they all start in the hypothalamus. The hypothalamus releases a hormone. In this case, it's GnRH, gonadotropin-releasing hormone. That's then going to act at receptors on the pituitary, which is going to release its own hormones. In this case, we have luteinizing hormone and follicle-stimulating hormone. That hormone is going to act at the ovaries, at FSH or LH receptors, and that's going to cause the ovaries to release hormones. In this case, they can release either estrogen or progesterone. And that estrogen or progesterone is going to go and it's going to affect any of the downstream target tissues. So uterine tissue, breast tissue, anything that we want that estrogen or progesterone to act at. However, to keep estrogen and progesterone from getting too high, we have to have negative feedback inhibition. When estrogen or progestin gets too much, we're going to come back and we're going to block GnRH release and block LH and FSH release. So we're going to look at this in a little more detail. First, I'm going to draw up here the monthly cycle, a hormonal cycle for women. This is going to help us kind of keep straight where we are. The first day of your period is considered day 0. Most women ovulate around day 14, and then day 28 is generally the end of the cycle. Women have different cycle lengths, but the average is 28 days. So we can look at the women's hormonal cycle as having two halves. With the first half, we're going to grow the endometrial lining, and we're going to start maturing an egg. In this case, we've got a lot of estrogen. That estrogen is going to go down. A little bump later, but it's going to go down through the month. Progesterone is going to be highest in the second half of the month, and it's going to come along and it's going to drop down, and that drop is going to cause the menstrual period. So in that first half of the cycle, you're going to be maturing eggs and increasing the endometrial lining, and then at about 14 days, you're going to release luteinizing hormone, which is going to actually stimulate ovulation. So these are the major things that we can look at as we're talking about these pathways. So in that first half here, the hypothalamus is going to release GnRH, which is then going to activate GnRH receptors in the pituitary. Now, an important thing about GnRH is it has to be released in pulses. So in this stage, GnRH is released in slow pulses over time, and that slow pulse tells those pituitary cells to release FSH. So FSH is being released in the first half. If we don't do pulses, but we just release GnRH at a steady level through the month, the pituitary would actually shut down. So it needs to see pulses of GnRH in order to respond. So you had that hypothalamus, had slow pulses of GnRH. That caused the pituitary to release FSH, which then came down to the ovaries and activated the follicles in the ovaries. So the follicles contain immature eggs. So when you activate those follicles, they're going to begin to mature the eggs until they're ready for ovulation. So over here we can see ovarian follicles are not only going to begin to produce eggs, but they're also going to start producing estrogen. So FSH begins the maturation of eggs, plus it starts the release of estrogen. That estrogen is going to do a lot of different things in the body, everything that estrogen does, but really importantly for reproduction, it causes the buildup of the endometrial lining. And so the endometrial lining is that blood lining tissue inside the uterus. And this is where, if there is fertilization, that's where an egg can implant to grow. So those follicles begin to produce maturing eggs, and the endometrial lining starts to grow. Like we said, we've got to have feedback inhibition. So estrogen is going to come up, and it's going to tell the hypothalamus and the pituitary that we've got a ton of estrogen on. But instead of completely shutting it down at the physiological levels, that estrogen is going to tell the hypothalamus to switch modes. So that's the point right here. When that estrogen level peaked up here, we then told the hypothalamus to switch over, and now it starts giving fast pulses of GnRH. You don't need to remember when it's slow and when it's fast. So that is activating cells in the pituitary and telling them to switch and stop releasing FSH, but to switch over to release LH. And you can see that up here, after the estrogen starts to peak, the luteinizing hormone is released, and luteinizing hormone is what tells the follicles to release the eggs, and that's ovulation. So back down here where we have our eggs, that LH comes, and now the follicle ruptures, and the actual egg is released, and then it's available for fertilization. So that's the main thing that luteinizing hormone does here, is it switches over and causes ovulation. The second thing that it does is that it tells the ovary to release progesterone instead of estrogen. So while estrogen built the endometrial lining, progesterone is going to maintain it. At this point, you don't want to build more endometrial lining because you don't want it to get too thick, but you also don't want it to go away because you need it in case there's fertilization. So in this phase, that second half, you have ovulation, then you have progesterone peaking, and if a pregnancy occurs, progesterone is just going to keep up and you're going to maintain that endometrial lining. If fertilization doesn't occur, then progesterone drops, and that drop is what causes the shedding of the endometrial lining and the beginning of a menstrual period. That maintained level of progesterone that's released by an embryo in the case of a pregnancy is going to now feedback inhibit up to the hypothalamus and pituitary again. So here's the progesterone, is going to come up and stop GnRH, FSH, and LH from being released. Because if you're already pregnant, you don't want to ovulate again. That does happen. It is weird. There are people, it's called supraovulation, and there are people who become pregnant and then a couple months later become pregnant with another fetus because they did not stop ovulating. Very rare. So first half, the hypothalamus gives a release of GnRH that causes the pituitary to release FSH, that causes the ovarian follicles to begin to mature eggs and to release estrogen. That estrogen causes the endometrial lining to grow and build. It then comes and the estrogen feedbacks onto the hypothalamus and pituitary, which now release LH, which binds to LH receptors on the ovarian follicles and tells them to go ahead and ovulate. It also comes back to the endometrial lining and says don't grow anymore, but stay here, retain in case there's a pregnancy. If there's a pregnancy, then the embryo will take care of everything from then on. If there's not a pregnancy, then the progesterone drops, and that causes the shedding of the endometrial lining, which is menstruation.